Good morning, dear colleagues. I'm glad to see you. I'm grateful to everyone who joined us this morning. I'm happy for the opportunity to share some insights on the MAC. My name is Oganesyan. My area of interest are the anterior segment of the eye, also cataract surgery, reconstructive surgery. But first of all, I am a keratotransplantologist. 18 years ago, I was lucky and honored to be one of the first who studied and mastered endothelial surgery techniques in NIEOS in Rotterdam. Before moving on to the MAC, let's go back to the keratoplasty history, or if you want, keratoplasty evolution, to understand the revolution in transplantation that happened 25 years ago. Here I show the main names, dates, and events thanks to which organ and tissue transplantation and corneal grafting in particular became possible. In 1813, Carl Himley proposed grafting clear cornea animals to blind animals. Later, Franz Reisinger did first penetrating keratoplasty on an animal and proposed xenotransplantation. Richard Kissam did first xenotransplantation from a pig in New York City. In 1830, von Walter offered lamellar keratoplasty. William Morton gave first general anesthesia. Semmelweis and Lister developed the principles of asepsis and antiseptics. In Vienna in 1884, Karl Köhler offered local anesthesia for eye surgery, and von Hippel later offered circular trephine. And finally, in 1905, Edward Conrad Zirm in Olomouc did the first successful allograft penetrating keratotransplantation. In fact, Dr. Zirm was not only the first person to perform a successful corneal transplantation, but also the first one to perform a multi-transplantation, an example of rational use of donor tissue. He did two same-time penetrating keratoplasty from single donor tissue. In 1931, Filatov in Odessa offered cadaveric donation, and in 1944, Richard Patton founded the first eye bank in Manhattan. 20th century was the golden age of the penetrating keratoplasty, but it ended 25 years ago. The development of phaco surgery, refractive technologies, and microinvasive surgery in general have opened our eyes in obvious disadvantages of penetrating keratoplasty, such as the sutures and the need to remove them, post-PK astigmatism, open sky surgery, long-term rehabilitation, difficulty of combined surgery, refractive error in triple procedure, the need of general anesthesia. In addition, the surgical scar after PK is not strong and is always dangerous in the case of blunt trauma. Nowadays is the era of selective keratoplasty, aimed at removing and replacing only the affected tissue and preserving healthy corneal tissue. Harriet Mellis is the godfather of modern endothelial keratoplasty. It's him who developed all modern techniques of endothelial surgery and Bowman layer transplantation as well. He also offered trypan blue staining in cataract surgery and in corneal transplantation. The first technique was posterior lamellar keratoplasty, PLK, or DLEK, deep lamellar endothelial keratoplasty in USA. The idea of PLK is to remove recipient's posterior stroma, destimate membrane with endothelium, by peripheral access, and so creating the bed on the posterior surfaces of cornea and sutureless fixation of the donor graft contain stroma, destimate membrane, and endothelium. You can see the borders of the graft inside of cornea. This is one of my first PLK cases, 17 years follow-up already. PLK has a very challenging surgical technique. For this reason, Mellis developed decimetorexis and destimate stripping endothelial keratoplasty techniques, DSEK. The idea of DSEK is to remove only destimate membrane and endothelium, destimate membrane with endothelium of recipients, and sutureless fixation of the donor graft contain stroma, destimate membrane, and endothelium. Ultrasyn DSEK, femtosecond DSEK, excimer laser DSEK, inverted femtosecond DSEK, and others have been developed later based on DSEK. Destimate stripping endothelial keratoplasty has quite an easy surgical technique, and at the same time, it has significant disadvantages such as increased corneal thickness, hyperopic shift, limited visual acuity, graft dislocation rate, rejection rate, interface quality, etc. For these reasons, Mellis developed destimate membrane endothelial keratoplastic technique, DMEK, which is the most effective technique of endothelial keratoplasty. The idea of DMEK is to remove only destimate membrane with endothelium of the recipient and to fixate the donor graft containing only destimate membrane and endothelium without sutures. Destimate membrane automated endothelial keratoplasty and destimate membrane endothelial keratoplasty with stroma, so-called DMAEK and DMAEK-S, have been developed based on DMEK, on DMEK later. It is some combination of DMEK and DSEK. The main DMEK disadvantages are challenging surgical technique of roll unfolding. It can be really difficult sometimes. And the second, it's challenging surgical technique of graft harvesting without tissue tearing. The next most common complication is a graft detachment, like in DSEK cases. But the main advantages are following: no astigmatism, best visual acuity in the shortest time, intact corneal architecture, fast recovery, close surgery, no sutures, low rejection rate, repeated DMEC at any time, and no need for expensive equipment. Also, DMEC technique permit use donor cornea after refractive surgery. And for example, here we can see the donor tissue after radial incisions. DMEC technique allows to vary the graft size and the graft shape. Quarter DMEC, so-called QDMEC, is a modification of conventional DMEC that allows to perform for...
Оганес Георгиевич, на секундочку, у вас пропал звук. Можете, может быть, сделать мьют и анмьют?
Так, попробую.
Ну-ка.
Меня слышно?
Не слышно, нет.
Не слышно. Так, раз, два. Нет. Сейчас слышно? Не слышно.
Maybe there are some issues with the connections here.
Но я вас слышу. Так.
It's muted now.
Yes, he muted him on purpose.
Okay, let's do unmute.
Оганес Георгиевич, можете включить звук, пожалуйста, себе?
Слышно?
Нет, нет.
Это может из-за видео?
Вот, сейчас появились.
Появился?
Ну-ка. Да,
Слышно
да,
меня? Раз.
да.
Давид, это может быть из-за видео быть? У меня много видео.
Ну, до этого было видео, да, никаких проблем не было.
Тоже было нормально, да?
Да. В общем, давайте продолжим.
Okay. So quarter DMEC is a modification of conventional DMEC that allow to perform 4 DMEC surgeries with single donor cornea. The surgical technique did not differ from conventional DMEC technique. In a few words, a main limbal tunnel incision of 1.6 millimeter making with a single paracentesis at 10 o'clock position. Decimeter X is performing under air, always bigger than the graft. The quarter graft injected into the host anterior chamber through the limbal incision and positioning centrally with the endothelium facing down and the anterior chamber completely filling with air. The technique of grafts preparation is following: Descemet membrane stripping from the posterior stroma. During stripping, the trabecular meshwork is kept intact and pulled together with Descemet membrane. After staining Descemet membrane, the tissue is positioned stromal surface down onto a soft contact lens, which is put on a barren punch. The peripheral rim with the trabecular meshwork is removed. We used a custom-made punch for linear cutting of Descemet membrane and obtaining 4 quarter pieces of Descemet membrane. We can use we can even use single cornea tissue for 5 recipients for 1 deep anterior lamellar keratoplasty bulk and for 4 quatadimec. Theoretically, the number of transplantations can be increased up to 6 if donor limbal tissue is used for allolimbal transplantation. Here, some images before 1 and 4 weeks after quatadestimate membrane endothelial keratoplasty. The next modification is hemidimec, which allows to perform 2 destimate membrane endothelial keratoplasty from a single donor cornea. Surgical technique did not differ from conventional DMEC or QDMEC technique. So we can use 1 cornea tissue for 3 recipients. Stroma can be used for deep anterior lamellar keratoplasty and destimate membrane for 2 hemidimec. Performing partial DMEC like QDMEC and hemidimec is absolutely logical because the pathological changes in Fuchs dystrophy are mainly limited to the central zone of the cornea. That does imply, however, that strict case selection for QDMEC is necessary. In addition, QDMEC allows retention of more host cells. At the same time, it creates favorable conditions for endothelization because the decimeter axis in partial DMEC cases is always bigger than the graft. So partial DMEC has some drawbacks: an acceptable increasing time for graft preparation, limited indications, prolongation of recovery time, and requires strict case selection and good logistics. So split and divide approach can reduce the need for corneal tissue. The main advantages of QDMEC and hemidimec is in a much more efficient use of donor tissue. Such approach could help dramatically reduce the shortage and the cost of the corneal tissue. More cases and long-term data are required now, of course. One more DMEC technique is so-called 3-quarter DMEC. It is well known that glaucoma drainage devices is a disadvantageous factor for graft survival after PK. Also, secondary graft failure after DSEC and DMEC in eyes with glaucoma drainage devices occurs in up to 35 to 74% of eyes at least 24 months. The rate of graft failure in eyes with glaucoma drainage devices is significantly higher than in eyes after glaucoma surgery without glaucoma drainage devices, and even more so in eyes with glaucoma surgery. The endothelial cell loss after DSEC in eyes with glaucoma drainage devices is around 61% during the first year, which is much higher than in eyes without glaucoma drainage devices. According to literature, graft failure in eyes with glaucoma drainage devices occurs earlier after DSEC than after PK. The mechanisms of endothelial graft failure in eyes with a glaucoma drainage devices is poorly understood. The most possible explanation might be mechanical damages of the donor endothelial cells by an intermittent or constant touch between the silicone tube and the graft. Other possible mechanisms include chronic pro-inflammatory, pro-apoptotic state of cells, chronic uveal inflammation induced by tube to iris contact, and glaucoma medication toxicity. There have been a few reports of DMEC for eyes with glaucoma drainage devices tubes, and a larger case showed good earlier outcomes, but high failure rates over the long term. Earlier, we introduced a 3/4 DMEC technique for optimizing the separation between the graft and the glaucoma drainage devices silicone tube for treatment pseudophakic bullous keratopathy. The technique of graft preparation is following: Descemet membrane stripping from the posterior stroma. During stripping, the trabecular meshwork is kept intact and pulled together with Descemet membrane. After staining tissue, it positioned stromal surface down onto a soft contact lens, which is put on bar and punch. The peripheral rim with the trabecular meshwork is removed. 2 perpendicular cuts performed with keratome directed to the tentor and triangularly shaped portion of Descemet membrane cut out. The absence of the graft under the tube prevent the contact between the silicone tube and the graft, which could be lead to chronic endothelial cell loss and graft failure. On patient's eye, Descemet Rex is creating under air, but with the portion of but with the part of the Descemet membrane under the silicone tube left untouched. The graft injected into the host anterior chamber through the main incision, positioned centrally and partially unfolding to achieve visualization of the site with a missing part, with a gentle tapping on the cornea to rotating the graft in the anterior chamber such that the missing portion of the graft relocating to the silicone tube projection. After the graft completely unfolding and the interior chamber fill an air. The absence of the graft under the tube could help avoid the contact between the silicone tube and the graft. Such contact after conventional circular DMEC may induce chronic endothelial cell loss and graft failure. To avoid or minimize cell migration from the graft onto the recipient stroma, the part of host Descemet membrane under the silicone tube is left untouched. The absence of chronic donor endothelial cell migration to the tube region may help retain the pool of donor endothelial cells on the graft itself. Using the large diameter grafts may compensate for the missing tissue quarter in terms of absolute cells number, especially since large diameter grafts include the cornea periphery, in which the endothelial cell density much higher. So this is my last slide in this presentation. So we demonstrate the technical feasibility of 3 quaternary in eyes with pseudophakic bullous keratopathy in the presence of glaucoma drainage devices tube, the absence of a donor destimate membrane and donor cells above the silicon tube excludes directed tube contact with the graft. Longer-term study are needed to show the effects of this modified graft pattern and dimensions on transplant survival. Dear colleagues, thank you for your kind attention. Thank you.